Good afternoon or good morning, wherever you are. My name is Robert Ross. I'm a physician assistant. My specialty is vascular medicine, specifically vascular ultrasound lab. Today, I'm going to present what do you really know about peripheral arterial disease, concentrating on awareness, diagnosis, and treatment, and also given a preview of office-based PAD evaluation and supervised exercise therapy, which is now covered by Medicare. Here we go. I have no disclosures. What do you really know about peripheral arterial disease? Our objectives are to review awareness, diagnosis, and treatment. So do you know the risk as defined by the American Heart Association, American College of Cardiology, and the American Diabetes Association for patients who have potential PAD? Do you know there is a test for PAD that is 95% accurate to diagnose PAD? And what do you know about treating patients who you've diagnosed with peripheral arterial disease? If you're not sure about the answers to these three questions, this presentation would be a great review to develop an excellent cardiovascular prevention program for all your patients at risk. The definition of PAD from the patient's perspective is my healthcare professional says the arteries in my legs are clogged. But what this really means, if the arteries in the legs are clogged, aren't the arteries everywhere else in the patient's body potentially clogged too, and just waiting for the end game to happen? Recently, the American Heart Association set out a scientific statement which urges greater attention to peripheral arterial disease. This was previewed in Medscape in their August 13, 2021 edition. The URL is listed here. Lower extremity peripheral arterial disease is underdiagnosed and undertreated in the United States despite its high prevalence and clinical importance. So says the American Heart Association. Dr. Michael Kricky was chair of the writing group. The article was published in Circulation on July 28th and is Lower Extremity Peripheral Arterial Disease, Contemporary Epidemiology, Management Gaps, and Future Directions, a scientific statement from the American Heart Association. So what does Dr. Kricky say? There continues to be a glaring need to recognize and treat peripheral arterial disease in the United States. While there has been increased awareness and better uptake of therapies over the years, PAD still lags well behind the other major atherosclerotic diseases, that is, coronary heart disease and ischemic stroke. What has increasingly been recognized is that if an individual has blocked arteries in the legs, they're also very likely to have blocked arteries in the heart and the brain. PAD is a very strong independent predictor of having heart attacks and strokes, and so it deserves attention for that reason alone. Difficulty walking itself is also a problem that can affect health because people may slow down and lose conditioning, so helping patients improve their mobility is critical. The first step is recognizing PAD and getting patients on the correct medications or other therapy. The American Heart Association currently recommends screening for PAD with an ABI in adults at high risk, namely those patients 65 years and older and those patients between 50 and 64 years with traditional risk factors. So what is our awareness we want to review? Do you know the risks? In the next 5 years, 1 in 4 of your patients with peripheral arterial disease will suffer a heart attack, stroke, amputation, or death. You, as a primary care practitioner, can change this outcome with the latest prevention, detection, and treatment strategies. The American Heart Association published an awareness document in 2005 listing the following risks for patients with PAD: age less than 50 years with diabetes and one other atherosclerotic risk factor, age 50 to 69 years and history of smoking or diabetes, age 65 years and older, leg symptoms with exertion such as claudication or ischemic rest pain, an abnormal lower extremity pulse examination, and known atherosclerotic carotid, coronary, or renal artery disease. Also, the American Diabetes Association in 2003 published an awareness document. The American Diabetes Association recommends that anyone over the age of 50 who has diabetes get screened for PAD, or under the age of 50 with multiple risk factors. The recommended test for PAD is the ankle brachial index. So now you know the risks. So let's become aware of what you can do. This is a scenario in which I'm sure every primary care professional sees many patients every day, week, and year with one of the following risk factors, which we just reviewed. But do you think of each patient as having potential peripheral arterial disease? Again, do these patients have PAD? Or do you just think the patient in room 2 is a 55-year-old male with diabetes, hemoglobin A1C 7.3, hyperlipidemia, LDL 125, on 2 blood pressure pills, and today you took your blood pressure, it was 142/88. Your patient quit smoking 5 years ago and has never told you his leg hurts when he walks. But have you ever asked your patient, hey, Billy, do your legs get tired, ache, or hurt when you walk 2 or 3 blocks or up 1 or 2 flights of stairs? Why would you ask Billy that question? He's here today to discuss his sugar, renew his meds. Maybe you'll give Billy some advice to help with his current issues and pat him on the back for continually not smoking. Yes, you've maybe never asked Billy if there was ever a complaint of claudication. That would have come up by now. You've been seeing Billy for about 10 years. But in 10 years, have you ever specifically asked Billy this question? Hey, Mr. or Miss PCP, Billy doesn't have to have claudication to have a diagnosis of PAD. If you're waiting for your patient to complain of claudication to make a diagnosis of PAD, you've waited approximately 10 years too long. PAD is not only claudication. PAD is clogged arteries in the legs related to systemic clogged arteries in all vascular beds throughout the body. If you've been seeing a patient for 10 years with the risk factors for PAD, and now 10 years later, the patient complains of claudication, you've failed in basic preventive medicine treatments for your many patients with potential PAD, because only 50% of patients diagnosed with peripheral arterial disease are symptomatic. The other 50% are asymptomatic. So if this is Billy and you're seeing him today and he tells you that he's getting claudication, or if you ask him and he says yes, maybe you could have prevented some of these factors 10 years prior if you'd have recognized the risks and used some prevention. So how do you diagnose peripheral arterial disease? Here's your normal artery and a PAD artery. So what should you do with patients who have risk factors with PAD, you might ask? Here are some suggestions. If you have a patient with risk factors, the American Heart Association, American College of Cardiology, and American Diabetes Association all recommend doing an ankle brachial index, ABI. Even if the patient does not complain of claudication, the ABI is 95% accurate for diagnosing PAD. Preferably, the ABI should be performed with a continuous waveform Doppler. A normal resting ABI should be in the range of 1 to 1.4. However, a post-exercise ABI is the best test to explore potential PAD. If exercise ABIs are not measured, you can miss 30 to 40% of patients with PAD. So after an evaluation of a resting ABI, the patient walks on a level surface for 5 to 6 minutes, approximately 2.5 miles per hour, followed by a repeat post-exercise ABI measurement. It's that simple. Other good physical exam screening techniques are palpate for pedal pulses, observe the hair formation below the knee, check for coolness of the feet. Most offices now have infrared thermography to check the forehead temperature. You can now check the same temperature of the feet with the same infrared thermography. Average temperature for a foot is 87 degrees or 30.6 degrees Fahrenheit. If the ABI is abnormal, the next vascular test may include duplex ultrasound or angiography. Hey, what if you had a patient that had an ankle brachial ABI, ankle pressure of 100, and a brachial pressure of 100? You divide the ankle by the brachial, and you get an ankle brachial index ratio of 1.0. But if you have a patient who has an ankle brachial index, ankle pressure 90, and brachial pressure 100, an ABI of 0.9 is equal to a 50% blocked artery in the leg. Most of these patients will not have claudication. They are asymptomatic PAD patients, but they have the same risk as anyone else diagnosed with peripheral arterial disease. So what are we going to do with treatment? The responsibility for detection of lower extremity PAD should be with the primary care provider. This was recommended in 2005 by the American Heart Association, American College of Cardiology. Now that you have assessed the patient, what are your options for treatment? Recommendations and review from the Mayo Clinic are reviewed here. The URL is listed below. Treatment for peripheral arterial disease has two major goals: manage symptoms such as leg pain so that patients can resume physical activities, and stop the progression of atherosclerosis throughout the body to reduce the risk of heart attack and stroke. You may be able to accomplish these goals with a lot of lifestyle changes for your patients, especially early in the course of peripheral arterial disease. If the patient smokes, quitting is the single most important thing you can help them do to reduce the risk of complications. Walking or doing other exercise on a regular basis following a schedule, such as referred to a supervised exercise training, which can improve the symptoms dramatically. If your patients have signs or symptoms of peripheral arterial disease, they likely will need additional medical treatment. You may prescribe medications to prevent blood clots, lower blood pressure and cholesterol, and control pain and other symptoms. Some of these medications will include statins, cholesterol-lowering medications, which we all prescribe every day. But PAD is a marker of systemic atherosclerotic disease and is associated with high rates of myocardial infarction, ischemic stroke, and cardiovascular death. In fact, cardiovascular events are higher in patients with PAD compared with those patients with already diagnosed coronary artery disease and cerebrovascular disease. It is therefore critical that clinicians interpret the presence of PAD as a herald of future cardiovascular events and respond by maximizing evidence-based medical therapies. The goals for people who have peripheral arterial disease is to reduce low-density lipids, LDL cholesterol, to less than 70. The goal is even lower if your patient has additional major risk factors for heart attack and stroke, especially diabetes or continued smoking. High blood pressure recommendation is to get the blood pressure of your patient to 130/80 with PAD, which is also the recommendation for all patients over the age of 65. Medications to control blood sugar, that is imperative. Medication to prevent blood clots, because peripheral arterial disease is related to reduced blood flow to limbs, it's important to improve that flow. You may prescribe daily aspirin therapy or another medication such as clopidogrel. Alternatively, you might consider anticoagulant therapy approved to reduce the risk of major cardiovascular events in patients with chronic CAD or PAD with the combination of rivaroxaban, 2.5 milligrams BAD with a low dose aspirin. Symptom relief medications, the drug cilostazol increases blood flow to the limbs, both by keeping the blood thin and by widening or vasodilating the blood vessels. It especially helps treat patients' leg pain in people who have peripheral arterial disease. Common side effects, headache, palpitation, and diarrhea. It is contraindicated in patients diagnosed with congestive heart failure. There's also mechanical clinical circulation support. Exercise is always recommended for kids with diabetes as a first-line therapy. However, several barriers are present in the elderly population. Low motivation to exercise, osteoarthritis, congestive heart failure, or chronic obstructive pulmonary disease preclude adherence to walking and active exercise regime. The Veno Plus vascular device offers healthcare practitioners a new therapy treatment plan for patients suffering with claudication limb pain and or tissue loss due to PAD. The Veno Plus device is a proven alternative to traditional exercise. The ultra-portable electromuscle stimulator with second heart TM technology treats calf muscle pump dysfunction. Every second, the Veno Plus delivers a comfortable electrical impulse, causing the muscle to contract, similar to what occurs when walking. During 1 hour of therapy, the calf muscle pump is activated 3,600 times as if the patient has taken 3,600 steps. This is approximately 1 mile of walking. Contraindications are pacemaker or defibrillator. Angioplasty and surgery are also options for those patients that have significant critical limb ischemia. In some cases, angioplasty and surgery may be necessary to treat the peripheral arterial disease and is now all easily prescribed and utilized in a local angioplasty lab. Supervised exercise program. You want to prescribe a supervised exercise training program to increase the distance patients can walk pain-free. Regular exercise improves symptoms of PAD in a number of ways, including helping the body use oxygen more efficiently. As an approved healthcare professional, you can now set up a supervised exercise training program at the outpatient office, and you're allowed to submit charges to many insurance companies for payment, especially Medicare. What if I told you for treatment, there was a treatment for adults with diabetes diagnosed with peripheral arterial disease, intermittent claudication that could, 1, reduce mortality from all causes by 54%. I don't know of any major pill that can do that. 2, lengthen the life of people with diabetes, regardless of age, sex, race, body mass index, length of time since diagnosed, and presence of complications or functional limitations. So no matter who they are, exercise will still help. Lower the mortality rate from all cause by 39%. Among adults with diabetes, 1 death a year may be prevented for every 61 people. This is treatment. Risk of death from heart disease could be reduced by 34%. If I could show you this treatment, would you start prescribing the treatment immediately? Let's see if you will. In 2003, an article was written, Relationship of Walking to Mortality Among U.S. Adults with Diabetes. The 5 examples I used in the previous slide, plus 4 more, are listed. Improving patients' health, especially if the patient walks 3 to 4 hours a week can reduce mortality from all cause by 54%. People with diabetes who walk for exercise at least 2 hours a week lowered their mortality rate from all cause by 39%. It's now in our hands. We can help patients live longer and live better by really enforcing and reinforcing exercise therapy. Another article written in 2018, Can Walking Reduce the Risk of Death? Absolutely shows that healthcare providers are used to dispensing advice on exercise. Providers can take different approaches, but current guidelines recommend a minimum of 150 minutes per week of moderate intensity exercise, or a minimum of 75 minutes per week of more vigorous intensity exercise. 150 minutes a week, 30 minutes, 5 times a day. That doesn't seem like very much to try and convince a patient to improve their health. Walking is the most popular form of physical activity in the United States, and it's really, really cheap, actually free. Walking has been associated with lower risk for type 2 diabetes and cardiovascular disease over and over again. Regular walking, even when it is below the minimum recommended levels for physical fitness, is associated with lower all-cause mortality compared with inactivity. The mean age of the participants was 71 years for men and 69 years for women. Even less than 2 hours of walking per week was associated with a mortality benefit compared with physical inactivity. Walking for 4 to 6 hours per week was associated with an even greater mortality benefit. The current study suggests that the healthcare team can encourage walking to reduce the risk for mortality among older adults. So now we know that PAD rehab is paid by Medicare. So how can you become a coach for your PAD patients and possibly set up your own supervised exercise program at your facility? Medicare, May 25th, 2017, approved supervised exercise therapy for beneficiaries with intermittent claudication for the treatment of symptomatic peripheral arterial disease. Prior to May 25th, 2017, the PAD rehab code was statutorily excluded from the Medicare program and no payment was made. For purposes of Medicare coverage, services must meet all of the following eligibility criteria. Consist of sessions lasting 30 to 60 minutes, comprising of therapeutic exercise training program for PAD in patients with claudication. Be conducted in a hospital outpatient setting or in a physician's office. So if you are not able to provide this program at your office, you want to encourage the hospital to include this with their cardiovascular exercise therapy program. It must be delivered by a qualified auxiliary personnel necessary to ensure benefits exceed harm. Definition of an auxiliary personnel person means any individual who is acting under the supervision of a physician or other practitioner to supervise the exercise in the office or the hospital. A set program provider must ensure all these criteria are met. For purposes of Medicare coverage, services must meet all of the following eligibility criteria. Be under the direct supervision of a physician as defined by code 1861 R1, a physician assistant or nurse practitioner or clinical nurse specialist as defined in code 1861 AA5, who must be trained in both basic and advanced life support techniques. So you must have your basic and ALS certificates before you can supervise. What is direct supervision? Appropriate physicians or non-physician practitioners can direct supervision which means that the physician or non-physician practitioner must be immediately available to furnish assistance and direction throughout the performance of the procedure. It does not mean that the physician or non-physician practitioner must be present in the room when the procedure is performed. In other words, the supervisor must be in the same building as the supervised exercise. Physicians, so there's no discrepancy, are defined as a physician in connection with the performance of any function or action, means a doctor of medicine or osteopathy legally authorized to practice medicine and surgery by the state in which he or she performs such function or action. However, podiatrists are excluded even though they are classified as physicians for providing supervision of peripheral arterial disease exercise therapy. For purposes of Medicare coverage, services must meet all of the following eligibility criteria. Beneficiaries must have a face-to-face visit with the physician responsible for PAD treatment to obtain the referral for supervised exercise therapy, either in the hospital or at the physician office. At this visit, the beneficiary must receive information regarding cardiovascular disease and PAD risk factor reduction, which could include education, counseling, behavioral interventions, and outcome assessments. MACs have the discretion to cover set beyond 36 sessions over 12 weeks and may cover an additional 36 sessions over an extended period of time. A second referral is required for these additional sessions. In other words, the patient could have 72 sessions or 6 months, 24 weeks of supervised exercise, which is reimbursed by Medicare. SET is not covered for beneficiaries with absolute contraindications to exercise as determined by their primary physician. For more information on this recent document, refer to the decision memo on supervised exercise therapy for symptomatic peripheral arterial disease at the URL below. So in Michigan, the reimbursement in a hospital setting per session is $54.55. In a physician office, the reimbursement per session is $19.83. What's the importance of exercise therapy? In looking at two very well-published studies, the change in pain-free walking time in minutes from baseline to 6 months. If a patient is advised to do a home-based exercise, the increased pain-free walking time is 1.43 minutes. For optical medical care in the Murphy study showed that the increased walking time was 1.2 minutes. For stent revasculation, 3.7, but for supervised exercise, a patient was able to walk pain-free for an additional 5.8 minutes. In other words, if a patient walked for 10 minutes and got peripheral arterial disease intermittent claudication symptoms, they could walk another 5.8 minutes after 6 months of therapy. This is very significant. So let's look at key elements of a therapeutic exercise training program for rehabilitation from peripheral arterial disease in patients with claudication. Role of primary clinician. First, you need to establish a diagnosis of peripheral arterial disease with an ankle brachial index measurement or other objective vascular laboratory test. You need to determine that the claudication is a major symptom limiting exercise. This can be done by performing a treadmill exercise ABI. You want to discuss the risks and benefits of therapeutic alternatives, including pharmacologic, percutaneous, and surgical interventions. You want to perform a treadmill stress testing, both cardiac stress testing and PAD, ABI before and after stress testing. Provide formal referral to a claudication exercise rehabilitation program, either at the hospital or setting up your own program in your own office. Exercise guidelines for claudication. You want to have the patient set up a warm-up and cool down period of 5 to 10 minutes. Types of exercise approved. Treadmill or track walking are the most effective exercises for claudication. Resistance training has benefit for patients with other forms of cardiovascular disease, and its use as tolerated for general fitness is complementary to walking, but not a substitute. In other words, the patients must be walking to become eligible for reimbursement for a PED supervised exercise program. The intensity, the initial workload of the treadmill is set to a speed and grade that elicits claudication symptoms within 3 to 5 minutes. Patients walk at this workload until claudication of moderate severity occurs, then rest standing or sitting for a brief period to permit symptoms to reside. Duration of the exercise. The exercise rest exercise pattern should be repeated throughout the exercise session. In other words, walk 5 to 10 minutes, rest 5 to 10 minutes, walk 5 to 10 minutes, rest 5 to 10 minutes. That usually takes up the recommended minimum of 30 minutes. You can do one more rest exercise, and that equals about 40 minutes. The initial session will usually include 35 minutes of intermittent walking to get them started. Then walking is increased by 5 minutes, either weekly or bi-weekly, until 50 minutes of intermittent walking can be accomplished. That is the goal. Frequency, treadmill or track walking 3 to 5 times per week, or 3 times in the office and another 2 times at home by your recommendation. Role of the direct supervisor. As the patient's walking ability improves, the exercise workload should be increased by modifying the treadmill grade or speed, or both, to ensure that stimulus of claudication pain always occurs during the workout. As walking ability improves and higher heart rate is reached, there is the possibility that cardiac signs and symptoms may appear. These symptoms should be appropriately diagnosed and treated. These general guidelines should be individualized on the basis of the results of treadmill stress testing, cardiac treadmill stress testing, and the clinical status of the patient. Full discussion of the exercise precautions for patients with concomitant diabetes, hypertension, or coronary artery disease can be found elsewhere. So now you know what the rules are from Medicare. How do you set this up if you decide to begin doing exercise therapy at your own office? First, you need to set up a log sheet to make sure that the patient logs in on the date, how many minutes they've exercised, and their initial or signature. This is provided for 36 sessions, approximately 3 months. At the end of 36 sessions, the patients must see the practitioner, the doctor, PA, or nurse practitioner, for an evaluation and to determine if another 36 sessions would be beneficial. This must be documented in the chart. Also must be reviewed if the patient is going to the hospital for rehabilitation and you want to continue the therapy. They must have a new prescription note. Another way to follow your patients is to encourage them to do walking on their own and keep a diary. What I like to call this their report card. These can be multiple copied and handed to the patient and reviewed at that 24-week or 12-week time. Also, you want to give the patient some information on why they should walk. The common explanations that were reviewed previously. So in 2005, the American Heart Association, American College of Cardiology issued broad-based guidelines for management of PAD. Newly formulated guidelines for the management of most forms of peripheral arterial disease were released in 2005 by the AHA and ACC, which are aimed at the wide range of health professionals who see patients with this disorder and emphasize the importance of prevention and early detection, the two societies announced. The chairman of the Guidelines Writing Commission, Dr. Alan Hirsch, stated, "We're saying to physicians for the first time," this was in 2005, "don't wait for the patient to complain to you about symptoms that they may not appreciate as hallmark signs of poor health. Ask specific questions to define high-risk groups and initiate early therapy to maintain functional independence and decrease the risk of heart attack, stroke, and death." The responsibility, as stated in the 2005 AHA guidelines, states is the responsibility for detection of lower extremity PAD should be with the primary care provider. An exercise ABI measurement can be useful to diagnose lower extremity PAD in individuals who are at risk for lower extremity PAD, as we've previously discussed, who have a normal ABI, are without classic claudication symptoms, and have no other clinical evidence of atherosclerosis. In other words, exercise ankle brachial index spots silent PAD, which was reviewed in an article in Internal Medicine in 2010. Many people have silent PAD that could be diagnosed with the exercise test, defined by the head physician investigator. It's a really important and easy test to perform. People with PAD are not always identified by their resting ABI. If exercise ABIs are not measured, you can miss 30 to 40% of patients with PAD. So let's review the awareness. You now know that all your patients with diabetes with one risk factor, any patient between 50 and 69 who you may be seeing with any history of smoking or current smoking or currently being treated for diabetes, all patients age 65 and older, any patient with leg symptoms such as claudication or ischemic rest pain, any abnormal lower extremity pulse examination. I hope you start doing pulse examinations on all these patients at risk. And any of your patients who have known atherosclerotic coronary, carotid, or renal artery disease, defined by the American College of Cardiology and American Heart Association, are at risk. The American Diabetes Association is very specific. All your diabetics should have an ankle brachial index recommended. Now, can you say, do you know, or no, you know, now think of each patient with the above risk factors as having potential peripheral arterial disease. I hope this is sunk in and you will take this to heart and use it on a daily basis. Here's what we recommend: that all patients diagnosed with diabetes or all patients age 50 and older fill out the PAD awareness questionnaire. This is an example of our questionnaire. It's handed out to every diabetic patient in a practice and all patients over the age of 50. The questionnaire is simple to review. Each risk is given a point system. At the bottom of the points are tallied up and the scoring is as follows. If a patient scores between 0 and 9, it's unlikely that they have peripheral arterial disease. You document it, maybe reassess them in 1 to 5 years. If a patient is 10 to 15, then that's questionable. The doctor, nurse practitioner, or PA can then determine if that patient falls in a risk category to have an ABI. If the patient scores 15 or more, there's a likely benefit from a painless, non-invasive test for peripheral arterial disease called the ankle brachial index. So quick facts about PAD. The most common symptoms of PAD involve the lower extremity are cramping, pain, or tiredness in the leg or hip muscles while walking or climbing stairs. Typically, this pain goes away with rest and returns when you walk again. Many people mistake the symptoms of PAD for something else. PAD often goes undiagnosed by healthcare professionals. People with peripheral arterial disease have a higher risk of coronary artery disease, heart attack, and stroke. Left untreated, PAD can lead to gangrene and amputation. If you've been waiting for a patient with the risk factors for PAD to come to you with complaints of claudication, you've failed in basic preventive medicine treatments for your many patients with potential PAD. Here's a resource for education for you and your patients on the American Heart Association, American Stroke Association website. The URL is listed at the bottom. So, what do you really know now about peripheral arterial disease? You've been given awareness, diagnosis, and many suggestions for treatment. Conclusion: the responsibility for detection of lower extremity PAD should be with the primary care provider. We know exercise works, supervised and home-based. Recommend it and prescribe it. I thank you very much for listening to this presentation. My information of contact is listed on this page. I have supervised or performed more than 70,000 lower extremity physiologic ultrasound studies, including ABI segmental pressure, pre and post exercise since 2003. Thank you for your attendance.